Hello everyone, I'm Dr. Monica. Today's video is about gingival recession. So let's begin with the topic. So according to Carranza, recession is the exposure of the root surface by an apical shift in the position of the gingiva. And according to Linde, gingival recession or the marginal tissue recession is the displacement of the soft tissue margin apical to the cemento-enamel junction with exposure of the root surface. Recession refers to the location of the gingiva rather than its condition. So a receded gingiva, it can be inflamed, but it may be normal except for its position. The prevalence, extent and severity, it also increases with age and it is more prevalent among the males. Gingival recession determines the position of gingiva. Looking at the diagram, talking about the apparent position of gingiva, it is the visible level of gingival margin which is seen clinically, or it is the level of the crest of the gingival margin. Whereas talking about the actual position of gingiva, it is the hidden portion of the gingiva or it is the true position of the gingival attachment which is determined by probing to locate the junctional epithelium, or it is the level of the coronal end of the epithelial attachment on the tooth surface. Talking about the primary causes of gingival recession, firstly we have is the low level and long lasting trauma. Due to chronic trauma and due to inappropriate daily brushing, dramatically using the toothbrush and other oral hygiene agents over the gingival margin daily can gradually and slowly lead to gingival recession over the years. So looking at the diagram, we can see U-shaped gingival recession associated with inadequate toothbrushing with cervical abrasion. Second cause is the chronic inflammatory periodontal disease. Due to the periodontal disease, there is tissue destruction which leads to gradual bone loss and lead to apical gingival migration and exposure of the root surface. So loss of the gingival tissue support as a result of enzymatic digestion and disorganization of the underlying connective tissue leads to presentation of gingival recession. In this diagram, that is, it is a CT scan which reveals the absence of apical as well as buccal bone plate of a mandibular incisor with gingival recession. Third common cause is the periodontal treatment. There is considerable tissue loss due to extensive periodontal disease or the need for tissue surgical removal. After performing the surgical procedures such as curettage and surgeries, there is decrease in periodontal tissue enlargement, which is temporarily induced by the inflammatory exudate accumulation. As repair evolves, there is decrease in the gingival volume and root exposure to the oral environment, which leads to the gingival recession. So the fourth cause is the occlusal trauma. On free surfaces such as the buccal one, depending on the cortical plate or buccal bone plate thickness, vertical bone loss results in local loss at the buccal bone level. This leads to bone dehiscence over the affected root, which is a V-shaped cavity in the bone contour, locally causing gingival bone support to decrease and presenting as gingival recession. This diagram represents buccal bone plate with severe canine dehiscence and premolar fenestration. So the gingival contour will keep up with the buccal bone contour, which results in V-shaped or angled gingival recession in teeth, which is affected by occlusal trauma and bone dehiscence or fenestration. Talking about the predisposing factors of gingival recession, first is the decreased alveolar bone crest thickness. It, along with the delicate gingival margin, it is commonly found in maxillary canines and mandibular incisors. Also, inappropriate toothbrushing and dental plaque buildup, it leads to early gingival recession. Second we have is the dehiscence, that is, there is reduced buccal bone crest thickness which presents with absence of buccal bone plate. Next we have is the frenulum insertion near the cervical region of gingiva. In this, the moving labial and the lingual frenum often leads to the gingival retraction, which causes gingival recession. So the potential consequences of gingival recession are pain. It is a common symptom linked with recession. That is, the presentation of cervical dentinal hypersensitivity is patient's primary concern in relation to recession and the reason for visiting the dentist. Second is the fear of tooth loss. It is also a common concern amongst the patient which presents the gingival recession. Also, patients are concerned about tissue loss which could affect the adjacent teeth. Thirdly, we have is the aesthetics. It is patient's principal concern relating to the recession, particularly in the anterior region due to the appearance reason. Next is the plaque retention and gingival bleeding. The site of plaque retention acts as an exacerbating factor in the progression of gingival recession at that site. Also, plaque retention and calculus formation in areas of localized recession will result in marginal gingivitis and ulceration, which may lead to gingival bleeding. Next is the presence of root caries. As root surfaces become exposed to the oral environment, there may be risk of development of root caries. Talking about the next factor, which is abrasion. Significant loss of hard tissue can occur when exposed root surfaces are subjected to oral hygiene measures, especially if the cleaning techniques are aggressive. So talking about the classification systems of gingival recession, there are many classification systems, but we'll be discussing few of them. One of the first classifications to be proposed was by Sullivan and Atkins in 1968, and the basis of this classification was the depth and width of the defect. So according to Sullivan and Atkins, there are four categories of gingival recession, which are deep wide, shallow wide, deep narrow, and shallow narrow. So this classification, though simple, is subjected to an open interpretation of the examiner and inter-examiner variability. Therefore, it is not reproducible. Next classification is by Mlinick et al. In 1973. In this, recession less than 3 mm is categorized into shallow narrow, whereas recession greater than 3 mm is categorized into deep wide. Next, Louis and Salt in 1980 classified marginal tissue recession into visual, which is measured from cemento-enamel junction to soft tissue margin, and hidden, which is measurement of loss of attachment within the pocket, that is apical to tissue margin. So next is by Benge et al. In 1983, who classified recession according to coverage prognosis. So there is U type, which shows poor prognosis, V type, it presents with fair prognosis, and there is I type, which shows good prognosis. So the most common classification for gingival recession was given by P.D. Miller in 1985 based on three factors, that is the degree of involvement of the mucogingival junction, the level of the proximal periodontal bone loss, and the alignment of tooth. So class 1 is the marginal tissue recession that does not extend to the mucogingival junction. Class 2 is the marginal tissue recession that extends to or beyond the mucogingival junction with no periodontal attachment loss in the interdental area. Whereas class 3 is marginal tissue recession that extends to or beyond the mucogingival junction with periodontal attachment loss in the interdental area or malpositioning of teeth. Whereas class 4 is marginal tissue recession that extends to or beyond the mucogingival junction with severe bone loss or soft tissue loss in the interdental area and or there is severe malpositioning of teeth. So Caro et al. In 2011 classified gingival recession based on the assessment of clinical attachment loss at both buccal and interproximal sites. So RT1, that is recession type 1, in this there is no loss of interproximal attachment. Interproximal cemento-enamel junction is clinically not detectable at both mesial and distal aspects of teeth. Coming to RT2, that is recession type 2, in this there is loss of interproximal attachment and amount of interproximal attachment loss is less or equal to the buccal attachment loss. Next is the recession type 3. In this there is loss of interproximal attachment and the amount of attachment loss is greater than the buccal attachment loss. So coming to the susceptibility factors and modifiable conditions associated with gingival recession. So susceptibility factors such as thin gingival tissue, gingival or soft tissue recession, absence or narrow band that is less than 2 mm of keratinized tissue, probing depth extending beyond the mucogingival junction, and positive history of progressive recession or inflammatory periodontal disease. The presence of these factors make the patients more prone to development of gingival recession. So the modifiable conditions associated with the gingival recession are clinically detectable plaque, bleeding on probing or inflammatory periodontal disease, shallow vestibular depth problem, frenum position problem, soft tissue clefts and deformities, subgingival restoration problems, damaging oral hygiene habits, damaging oral habits or eating habits, clinically significant root sensitivity problems, oral appliance problems, dental therapy that can cause inflammation or tissue injury, orthodontic tooth movement, poor metabolic control of diabetes, and tobacco use, including smokeless. So, these conditions, whenever they are corrected or modified, can reduce the chance of development of gingival recession. Coming to the management of patients with gingival recession. Whenever there is presence of recession, we will look for patients' concerns, that is aesthetics or presence of root sensitivity. If patients' concerns are absent, we will look for active recession, that is determined by comparing the size of the current lesion to patient's previous record. Then if active recession is not there, we will look for restorative or orthodontic needs. If these needs are present, we will look for predisposing morphological factors, which may include inadequate keratinized mucosa, frenum pull, thin tissue type, which might increase the risk of future recession. If these morphologic factors are absent, we will monitor the recession. But in case of presence of patient's concern, presence of active recession, or if there is predisposing morphologic factors, then first thing is we will modify the precipitating factor to reduce the inflammation, and after the inflammation reduces we will consider a periodontal plastic procedure like free gingival graft or root coverage procedure. Coming to the modalities of treating a gingival recession. So, a gingival recession can be treated by either root coverage or by augmenting the keratinized tissue. The coming to root coverage, the main goal is to augment the soft tissue coronal to the gingival margin. Main purpose is to cover the root, increase tissue thickness, and increase the keratinized tissue width. So, the available procedures for root coverage are pedicle flaps, coronally advanced flap along with subepithelial connective tissue graft, coronally advanced flap and uh, allografts or xenograft, coronally advanced flap along with biologics and tissue engineering procedures. So it is mainly used in Miller class 1 and class 2. It is favorable and it is less to unfavorable whenever it is used in Miller class 3 and class 4. Coming to augmenting the keratinized tissues, it provides qualitative changes to the soft tissues apical to the gingival margin. Main purpose is to increase the tissue thickness and increase the keratinized tissue width. So the available procedures are free gingival graft, use of allograft or xenograft, or tissue engineering.
Please like and subscribe to this channel. Thank you.